Hello students, welcome to Nutritional Support for Cancer and HIV Patient Part 2. Right now, we're going to talk about human immunodeficiency virus, progression of human immunodeficiency virus. According to the CDC, about 38,700 people are infected with HIV every year in the United States alone. Approximately, this is 81% of whom are male. These statistics are very shocking. Evolution of human immunodeficiency virus. Scientists identified the earliest known case of AIDS in a blood sample collected in 1959. So we are kind of reviewing some part of the history, which is very important, from a Bantu man living in what is currently the Democratic Republic of Congo, an area from which the current world epidemic is believed to have originated. Now, scientists discovered the underlying infection agent in 1983. The French scientist Lou Montagnier is leading pioneer in AIDS research, reported that he and his team at the Pasteur Institute in Paris had isolated the viral cause, which we know now as HIV. Parasitic nature of the virus. This is where we need to pay attention to this, because this is very important. No virus can have a life of its own, okay? Because of their structure and reproductive nature, viruses are the ultimate parasites. They are mere shreds of genetic material, a small packet of genetic information encasing a protein code. So viruses only contain a small chromosome of nucleic acids, which is your RNA or DNA, usually with fewer than 5 genes. They can live only throughout a host that they invade and infect, and they hijack the host cell's machinery. Wow. They hijack the host cell's machinery to make a multitude of copies of themselves. That's why they are so dangerous, and they replicate in such a speed that we cannot control. Okay, now cultural considerations. More than 1.1 million people in the US are currently living with HIV, and an estimated 14% of them are unaware of their infection. 14% is a huge number of people that they don't know they are having HIV, and we are going to know why. Okay, so here we see African Americans are leading these statistics. Then the white people, I would say Hispanic is in the second place, and then white. Okay, so high risk heterosexual activity and injection drug use are the next common causes of HIV transmission. These are the reference from the CDC. Transmission and stages of disease progression. An infected person can transmit HIV to another person through sexual contact, through the sharing of needles or syringes, or through mother-to-child transmission. So there you go. You have three transmissions pathways, right? Through sexual contact, through the sharing of needles, or through mother-to-child transmission. The individual clinical course of HIV infection varies substantially, but the following 3 distinct stages mark the progression of the disease. So, acute HIV infection, clinical latency, HIV inactivity or dormancy, and AIDS. Okay. These are 2 classification systems for staging HIV. There are 2. The CDC classification system and the World Health Organization clinical staging and disease classification system. Now, the CDC classification system assesses HIV stages based on the lowest documented helper T white blood cell count. Remember, the CD4 cell count, stages 0, 1, 2, 3, and unknown. Okay, and the presence of a specific HIV-related opportunistic illnesses. So first, it depends on the amount of helper T cells, okay, and the HIV-related opportunistic illnesses. Now here we have this graphic. We can see the light blue is male to male sexual contact. Here we have the heterosexual contact in females. This is the mode of HIV transmission for male and female. So in females, the heterosexual contact is the one that is more frequent. In males, the male to male sexual contact. So basically, sexual contact is the key here. CDC classification system for HIV, stage 0, okay, is an early HIV infection inferred from a negative or undetermined HIV test result within 6 months of a confirmed positive test. Okay, that's the difference between stage 0 and stage unknown. HIV test positive, but no CDC4 T lymphocyte count available. That's the other one, right? So that's good to know. You need to know your stages. It's very important because these are NCLEX alert. I've seen these questions before, NCLEX alert. You can ask different nurses, different students that took the NCLEX if this is true or not, but I've seen it. After the physician has determined the patient stage relative to the CD4 and lymphocyte and T lymphocyte count, the healthcare team will assess the patient clinical category relative to his or her symptomatic condition. For example, category A is asymptomatic or acute HIV. Okay, and in this category, we're gonna have flu-like symptoms. Asymptomatic, so some flu-like symptoms. That's good to know. Approximately 2 to 4 weeks after initial exposure and infection, a mild flu-like episode may occur. This reflects the initial development of antibodies to the viral infection. For a number of years, the person typically feels well. Wow, for a number of years, the person feels well. That's why there is a 1.1 million, as we were reviewing at the beginning of this part 2, that they are unaware they are infected with HIV. It is a critical stage of viral incubation. The virus is hiding in lymphoid tissues, meaning lymph nodes, spleen, adenoid glands, tonsils, where it rapidly multiplies as part of its parasite life cycle within the host, taking over more and more of the host CD4 cells and gaining power. Okay, so early, and this is the category in which the virus is kind of dormant. Early treatment may slow the viral strengthening time. So that's why it's important to get tested and kind of diagnose, because early treatment is the key to prevent further problems with this disease. Category B is symptomatic condition. So after this asymptomatic HIV positive stage, associated infection illnesses begin to invade the body. Now the patient is having symptoms. This period of opportunistic illnesses is so named because at this point, the HIV infection has killed enough host protective T lymphocytes to damage the immune system severely, and to lower the body's normal disease resistance so that even the most common everyday infections have an opportunity to take root and grow. Common symptoms during this period include persistent fatigue, diarrhea, and fever, mouth sores from thrush, which is your Candida albicans, night sweats, unintentional weight loss, remarkable headache, shingles, cervical dysplasia, or carcinoma, new or unusual cough, unusual bruises or skin discoloration, and peripheral neuropathy. So, as a provider, when I see somebody that is losing weight unintentionally, immediately I'm going to ask, are you sweating at night? How much are you sweating? Are you changing t-shirts at night? Are you having any unusual cough? And while I am asking this, I am doing my assessment. I am checking the lymph nodes around the neck, the ones under the axilla, right? So we want to know, are you having fever? Very commonly, headaches, right? And I'm going to check for bruises and skin discoloration. That's very important because from there you can assess if the patient is having HIV or is a kind of lymphoma or any other type of cancer, right? Now, category C, AIDS indicator conditions, rapidly declining T lymphocyte counts and the presence of opportunistic illnesses mark the terminal stage of HIV infection known as AIDS, right? So we have Kaposi sarcoma is the most common AIDS-associated cancer. AIDS stands for Acquired Immunodeficiency Syndrome. Malignant and rapidly growing tumors of the skin and mucous line of the GI and respiratory tracts characterize Kaposi sarcoma. Again, malignant and rapidly growing tumors of the skin and mucous lining of the GI, so you can see it from the mouth all the way to the anus, and respiratory tracts characterize Kaposi sarcoma. The healthcare team may use low-dose radiation therapy or anti-cancer drug to slow the spread of tumors. So now we are having the CDC classification system for HIV, and that's good to know. For AIDS, it's important to classify the rapid decline in T lymphocytes. So we need to know how fast the lymphocytes are declining. So we have certain categories. We have first the CD4 and T lymphocyte. We have stage 1, which is more than 500. Stage 2, look, it's very important. Only one cell, one T lymphocyte make a difference between stage 1 and stage 2, which is between 200 and 499. Stage 1 is more than 500. And then stage 3 is below 200. So one T cell, T lymphocyte, is important. Now, you can have a stage 1 with C1, means the presence of opportunistic infection, right? Or you can have a stage 3 less than 200 with C3. Okay, so you have to consider both factors for the HIV classification. Now, you should memorize your levels, your stages, okay? Common types of opportunistic infections in clients infected with human immunodeficiency virus. Candidiasis is very common. It can be in the bronchi, trachea, esophagus, or lungs. Cervical dysplasia, it could be invasive. Now you have cytomegalovirus disease. Okay. Cytomegalovirus disease, specifically retinitis, so it's going to be an eye condition. Encephalopathy, HIV related, that means is related to the brain. Herpes simplex, chronic or bronchitis, pneumonitis, or esophagitis. Histoplasmosis, Kaposi sarcoma, the one they described a few minutes ago in the book. Lymphoma, related to the lymph nodes. Tuberculosis, Mycobacterium avium complex, and I want to make a stop here because I want to explain that Mycobacterium avium complex is a bacteria in soil and water that cause this disease, lung disease in older people, or those with weak immune system or respiratory problems. Most people with MCA, MAC, need several different antibiotics for more than 1 year to get rid of the infection. MAC lung disease is a type of non-tuberculosis mycobacterial infection. Unlike tuberculosis, is not contagious. That's why I stop here, because I want to clarify it's not a contagious tuberculosis, right? Then we have Mycobacterium kansasi, okay? It's a slow-growing, non-tuberculosis mycobacterium. That's why I stop also. Like other mycobacterial species, tends to cause 6 clinical patterns of infection: pulmonary disease, skin and soft tissue disease, musculoskeletal infections, including monoarticular septic arthritis and synovitis, disseminated disease, catheter-associated disease, and lymphadenitis. Chronic pulmonary cavitary disease in the upper lobe is the most common presentation of Mycobacterium kansasi infections, and patients may initially be misdiagnosed with pulmonary tuberculosis. So when they see the presentation in the upper lobe of the lung, probably they are gonna misdiagnose as tuberculosis. So you have to pay attention of the other symptoms and request the doctor to do a very thorough diagnosis and analysis because the treatment is going to vary. For regular contagious tuberculosis is one type of therapy, medication therapy, and for this one should be another one, right? So now Salmonella septicemia recurrent, and then toxoplasmosis of the brain. And then with toxoplasmosis, let's make another stop. Toxoplasmosis is an infection caused by a parasite, Toxoplasma gondii. Pregnant people can pass the infection onto a fetus. Those with weakened immune system are at risk for life-threatening complications. You get this toxoplasmosis after contact with cat poop, feces, or eating contaminated food, right? So all those TikTok, Instagram videos in which the cat is kissing a baby, or they put the cat sleeping next to a baby, you're putting your baby in risk for toxoplasmosis. Anyway, so medical management of the patients with HIV and AIDS. Basic goals are to achieve the following: early diagnosis and treatment initiation. That's good. Delay the progression of the infection and support the immune system. That is going to be as a consequence of an early diagnosis. And of course, we're going to prevent opportunistic illnesses. Initial evaluation and goals. So this professional team is going to include the medical, the nutritionist, the nursing, psychosocial, healthcare specialists, and others as needed on the individual basis. The current HIV screening guidelines recommend HIV testing for all individuals age 15 to 65, all pregnant women, and other deemed at high risk or who request testing. Now, drug therapy. Nucleotide reverse transcriptase inhibitors, your NRTI, that inhibit the virus necessary enzyme for copying itself. So the virus, you know, is stealing your mechanism, the host mechanism, in order to reproduce. So this type of medications are going to inhibit the virus necessary enzyme for copying itself, thereby effectively preventing viral increase. Okay, that's one. Then we have multiple toxic side effects have been reported, but some of these are nausea, diarrhea, altered state, hyperglycemia, GI intolerance, may be helped by dietary modifications or anti-nausea, anti-diarrhea medications. So here we have to consider if the patient is diabetic. We don't want to put the patient in hyperglycemia or a state, right? Then we have the non-NRTI, the non-nucleotide reverse transcriptase inhibitors. Also, we have the protease inhibitors, protease inhibitor, fusion inhibitors, entry inhibitors, latency reversing agents, attachment and post-attachment inhibitors, and HIV integrase inhibitors. So, for example, the protease inhibitors help to stop HIV by inhibiting the basic enzyme protease, which is produced by the pancreas, which is essential to HIV development. Protease, right? It's going to metabolize the proteins, okay? And that's for general information, but protease inhibitors is something that you have to remember because it's going to inhibit the basic enzyme protease, right? Vaccine development, the CDC and the National Institute of Health are involved in coordinated vaccine research in the United States, and they are working in conjunction with other agencies worldwide to expedite the development of a more effective vaccine. After they identify a potential vaccine, it must go through the following 3 phases of testing and be deemed safe and effective before the FDA will approve for public use. So in phase 1, the vaccine is tested in small groups. In phase 2, the vaccine is tested in hundreds of high-risk and low-risk participants. And phase 3, the vaccine is tested in thousands of high-risk participants for safety, efficacy, and side effects of the vaccine. A combination medication consisting of tenofovir, disoproxil fumarate, and M3-citravine is an effective pre-exposure prophylaxis that the FDA has approved for use in the United States. So be familiarized with this medication, right? Because we're going to talk about it in 201 when you get to the 4th semester. Medical nutrition therapy in the patient with HIV, nutrition-related complication of HIV, as they do with cancer. Individual nutrition problems throughout the continuum of care for HIV patients vary greatly depending on the stage and the opportunistic infection conditions present. And due to and medication-induced metabolic disturbances can considerably alter the individual's nutrient requirements. In addition, comorbidities, opportunistic illnesses, and treatment regimen further influence the degree of nutrition-related complications a person may experience. Common comorbidities includes cardiovascular disease, this is very important, obesity, osteoporosis, diabetes, cancer, liver disease, and malnutrition. Now, wasting effects. Clients with advanced stages of HIV regularly have a decreased appetite and an insufficient energy intake coupled with metabolic dysregulation. Significant weight loss follows and eventually leads to cachexia, that is similar to cancer cachexia. Malnutrition suppresses cellular immune function, thereby perpetuating the onset of opportunistic infections. Now, the characteristic body wasting of HIV infection may result from any of the following processes, either alone or in combination. So we have inadequate food intake. An important factor in the profound weight loss seen in HIV/AIDS patient is anorexia. That's why there is inadequate food intake. Now we have malabsorption of nutrients, drug diet interaction, and the progressive effects of HIV infection commonly manifest as diarrhea and malabsorption. Then we have the disordered metabolism. Some patients with HIV experience elevated resting energy expenditure and abnormal macronutrient metabolism. And finally, lean tissue wasting. Terminally ill patients who are undergoing extensive medical therapy with a multitude of negative side effects are not likely to participate in regular physical activity or exercise. Now we're gonna start talking about lipodystrophy. This is extremely important. It's a disproportionate gaining of fat mass in the neck, and you can visually recognize this type of patient. So the gaining of fat is going to be around the neck and the abdomen, with a concurrent loss of body fat in the face. So around the neck you're going to see a lot of fat, but the face is going to be thin, right? And also the buttocks, arms, and legs are going to be the patient is going to lose body fat in that area. So this contributes to the development of chronic kidney disease and cardiometabolic comorbidities, hypertension, dyslipidemia, and insulin resistance. Yes, especially if you are accumulating body fat in the abdomen. The most well understood causative factor for lipodystrophy is treatment with antiretroviral therapy. Again, the most well understood causative factor for lipodystrophy is treatment with retroviral therapy. So these patients are having this therapy, but also they are putting in risk their kidney conditions, the cardio, right? So it's risk versus benefits that we need to consider. The dietary recommendations are to follow a well-balanced diet that is particularly heart healthy, such as those discussed in the previous chapter, DASH diet or Mediterranean diet. So the patients that are having retroviral, antiretroviral therapy, and they are having the fatty tissue around the neck and the abdomen, they need to do the DASH and the Mediterranean diet, a Mediterranean diet. And that's good to know. Good to know. Highly effective antiretroviral therapy and lipodystrophy. That's something for you to read. Now, nutrition her plan. The role of the nutritionist is to help maintain the health of HIV patient as it relates to nutrition through education and nutrition support as their common requires. Then we have the assessment. In the assessment, there are specific nutrition status screening tools available for use in individuals with HIV, such as the Subjective Global Assessment HIV. Such a screening tool will identify patients at risk for malnutrition quickly and efficiently to expedite their referral to a nutrition professional. Then we have the assessment should include the typical ABC nutrition evaluations. What is the ABC? Your anthropometrics, your biochemical, your clinical and dietary parameters, and those we review in, I think it's the second chapter in this semester. Okay, so if you want to review and kind of analyze what is your anthropometrics, I invite you to do so, right? Now, clinical applications. So we are going to do the basics ABCD, gerontoprometic, biochemical, clinical, and dietary parameters, but also we are going to provide a practical guide with 2 more points added for HIV infected individuals. So besides the ABCD, we are going to do E and F. What is E? Environmental, behavioral, and psychological assessment, and financial assessment, because we need to know if the patient is going to be able to follow the recommendations, right? Intervention. Nutrition care process includes planning, implementing, and documenting appropriate patient-specific intervention. So the key nutritional therapy objective is to reduce or eliminate malnutrition and to correct nutrition problems that the dietitian identify in the nutrition assessment. And we know that. That's why they do this assessment, to correct and to planify, to elaborate a care plan. The dietitian should address the prevention of foodborne illness through appropriate cooking and storing food methods during nutrition counseling. The healthcare team should also discuss complications, food medications, use of complementary and alternative medicines. Nutrition counseling, education, and supportive care. So we have to provide education in terms of adequate food intake to maintain appropriate body composition and nutritional status, a review of nutrition strategies and additional therapies, food safety and food security, and potential drug-nutrient interactions. That's good to know. To promote optimal nutrition with fewest food changes. So the most important is, because not everybody is going to be motivated to make radical changes. So that's why we need to promote optimal nutrition with fewest food changes, right? The basic goal of nutrition counseling is to make the least amount of changes necessary in a person's lifestyle and food patients to promote optimal nutrition status while providing maximal comfort and quality of life. So we need to assess for motivation, we need to assess for rationale, for manageable steps, right? And personal food management skills. We need to talk with the patient, and the dietitian is also responsible for establishing patient-specific dietary plans that support their medication regimens. This may include individualized plans for meal timing, macronutrient and micronutrient modulations, and symptoms management. There are community programs like Meals on Wheels for the delivery of prepared meals when the person is too ill to shop for food or prepare it. And that's something that we are blessed to have this here in US. Information about food assistance programs like the Supplemental Nutrition Assistance Program, our SNAP, or food commodities. Also, our psychosocial support. Major stress areas include issues related to autonomy and dependency and sense of uncertainty and fear of the unknown. And that's something that we need to consider, because the patient is going to be in grief, change, and loss, fear of symptoms and abandonment. Spirituality and quality of life also must be addressed, and we need to see if we can provide support with the proper referral, right? It's very important. That I would say the most important part, besides assessing for nutrition, we need to assess the motivation of the patient, and we need to help the patient to get rid of the fear so they can face and they can fight for their well-being. Okay, so here we have concluded this chapter related to the nutritional support for cancer and HIV patients, and see you next time. Thank you for watching.